Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Max and Morgan, and I would like to talk about optimizing your patient for evac. How you guys doing?
Good.
Doing great.
Thanks for having us on.
Outstanding. So, Max, if you would, just do a real quick introduction for yourself, please.
Sure. So I'm Max. I'm a former Army flight medic and civilian paramedic. I spent about 16 years in the Army with a couple of conventional tours as dust off over in Iraq and Afghanistan. And I have since left the Army, and I'm on a track towards med school and pre-med. So getting that big brain energy on. And then in between classes, I'm also doing a lot of teaching.
Outstanding. Hey, Morgan, how you doing?
Yeah, my name is Morgan. I'm a flight paramedic in the Oregon Army National Guard. And I've just kind of wandered around doing different jobs in public safety. I was a firefighter and as a Secret Service agent. I started out before all that in the Coast Guard for a while, so just kind of done some different stuff here and there, but right now I fly in the back with the Oregon Army Guard.
All right, outstanding. So, with all that stuff out of the way, I think first let's start off with some real common mistakes, when you're doing your evacs. And, you guys hit the ground, you got the ground medic handing off a patient. Like, what are the common mistakes you guys are seeing as far as having a patient prepared to be evac'd?
Yeah, that's a great question. And I think there's four primary things that I've seen over the years. And they come down to documentation, securing procedures, making sure that, whatever you put in the patient stays in the patient. The nuances of a good handoff between medical providers, and then just the general preparation for flight and making sure your patient's sort of in a physical state to make the journey from point of injury back to medical care. So I can hit on each one of those if you'd like.
Yeah, absolutely.
So for documentation, a lot of times when we land wherever you guys are, whether it's a secured compound or at the point of injury, there's generally it's a very kinetic environment. So, all of a sudden there's a running helicopter in the middle of your compound, and it's noisy, it's kinetic. You want to get the patient out of there. And so it's not really a conducive environment for communication. And so any documentation that you can provide is just essential, whether that's as simple as a TCCC card or as extensive as all of the PFC worksheets and documentation. That paper trail is really important for us, especially on longer evacs. As far as securing procedures goes, it's sort of an unfortunate side effect of the operational environment. Stuff just gets ripped out, and while preparing for evac, while waiting for the evac platform, whatever that may be, to show up, just taking some extra time to secure IVs, secure chest tubes, and make sure that, especially securing airways, anything that you want to stay with the patient is secured to the patient. Because, you never know in those first few minutes of transitioning care what's going to get snagged on the inside of the helicopter and what people are going to, rip out while they're doing their initial assessment, and it can get pretty chaotic. So anything that you put in, make sure it's fixed to stay in. And then for the handoff, so I think the principle, tell me what I can't see, that was brilliant. So, I can come up to the patient, I can see pretty clearly that, he's got big holes in him or he's missing body parts. But I can't see what you gave him for sedation and how much and how long ago. I can't see, other things that you've done to temporize this person's situation. And so, that becomes the critical line of communication. So I can pick up where you left off. So, if he needs that infusion of antibiotic that you didn't start, well, I got 30 minutes to the operating room. I can definitely hang that bag of Invans or whatever I need to do. And then the last one is just prepare for evac, just the general physical state of the patient. I've picked up a lot of naked people on Talon litters, and we're getting to the point where we understand that that's just not satisfactory. So the environment on the ground is a bit different than the environment in the back of the helicopter. And what we see is that there's a lot more convective cooling of our patients, especially on these mesh litters, especially if we are in a situation where we have to fly with the pilot's doors removed or the gunner windows open. There's a lot of convective cooling. And so these patients, if they were hypothermic, on the edge of being hypothermic on the ground, they will just be popsicles by the time we bring them into the OR. And it's difficult inside of a flying aircraft to roll these patients and get them inside the HPMK. It's much easier to do that sort of thing when you're on the ground. And so just the general preparation for, thermal considerations, also making sure that they have earplugs or headphones on before we load them into the helicopter, just because the intensity of the sound from inside the helicopter over that period of time is going to cause damage, just physical damage, whether they're conscious or not. So preserve their hearing and sort of prevent that long-term morbidity. And then, just making sure that we reinforce those interventions, because, it really sucks when you go to administer medication and you realize that the IV's been ripped out. Mm-hmm.
All right. Just a quick follow-up question to that. So documentation, let's say you're coming to pick up my patient. I've been working on him hard and fast, and I see your helicopter maybe a couple miles out. I think I have about 45 seconds until you land. I have not yet filled out my T-Tri-C card because I'm doing awesome medicine. What do I need to document for certain?
I think the things that would help us most, going back to something that you had said before we hit record, is all the things that we can't see. The very first thing I'm going to do when the patient lands in the helicopter is, do a head-to-toe assessment. Follow that march sequence. So I'm going to be finding all the amputations. I'm going to be finding all the big holes and all your treatments and things like that. If I'm doing a good job. But what I'm not going to see is that gram of TXA or, the ketamine that you gave him. And so that stuff, whether you have to write it with a Sharpie on his chest or you can quickly scribble that down on the T-Tri-C card, any way that you can communicate those things that I can't see is going to just maintain that continuity of care. Yeah.
Guys, I think, fail to realize how really dangerous this period of time is in this handover. Just because, you kind of assume like they're going to a higher level of care. So, whatever I've done wrong, they can fix type of thing. But this is a really dangerous time. So I've had, X period of time to figure out what's wrong with this patient right now and start working to move this patient forward. But you're just getting eyes on him right now. So anything I can give you that's going to kind of speed up that process, like you said, the things you can't see, it's just going to kind of ensure that you don't jump to any conclusions or you don't kind of have a false impression of this patient and start doing treatments for that based on, just on appearance because I didn't document something properly.
Yeah, absolutely.
Throw a couple. Do you mind if I? Just throw a couple other things in there that the one component that I would emphasize as well is obviously if we're doing all this in the 1 digit minutes post injury, that's not prolonged field care. It probably doesn't super relevant to this, but if it's been a bit and you've been on that patient for a while and you have had an opportunity to administer pain medication, as a style point, knowing how that patient was doing, knowing that patient's mental status before the administration of the medication, especially ketamine, is very important for us, because it's very important for the treating physician to know their status before then. If you haven't given ketamine, it's an amazing medication, but it really profoundly alters a lot of people's mental status, and that can mask some other symptoms, and it can also lead, even the best physician down the wrong road. Yeah. And so I think that's a really important component of a handoff. If pain medication has been administered, we got to know how that patient was doing before, because they're going to be real different after that pain medication gets on board. Mm-hmm. The other thing, I hate to be the guy that beats the drum for the really easy or sort of obvious points, but preparing yourself and your team for a helicopter coming down on top of you is really important. And I can't emphasize enough, like all your stuff is going to go everywhere, and it can be, it can really kind of screw up everybody's day if something, gets clipped by a rotor or sucked into an engine or something. So it doesn't, it seems like really obvious, but, I've hoisted in to scenes and seen hats go flying, and it's kind of, low hanging fruit. That's kind of easy to fix when you do hear that helicopter coming in. So stuffing those loose items. Yeah. And, if this is like a rushed handoff, I think that, the COROM, the College of Remote and Offshore Medicine, has a great little acronym for a quick handoff. CPRO, CPRO is cap refill, pulses, respirations, and oxygenation. I think that's like a really valuable handoff. Mnemonic, AT mist, whatever. Pick something and make sure that you're covering all those, because those mnemonics, in a lot of cases, have withstood the test of time and can really convey a lot of information downstream. And I guess the last point that I would make is, like, if you are kind of white knuckling it, and I think, Dennis, you were kind of alluding to this, if you are kind of white knuckling it and thinking, you're just going to get the patient ready for the helicopter door to close and to see that aircraft go wheels up, that's going to be really, really complex. And Max has made this point before, that a good paramedic, the mark of a good paramedic is being able to anticipate their clinical course. And so to the extent that you can think not just about the 45 seconds into the future, but think about the 2-hour transport time potentially, and how you can, as the initial treating medic, facilitate good care over that prolonged transport. That's going to be very helpful to us, because although we have a lot of stuff in the aircraft, it's just really, really tough to use it.
Mm-hmm. Oh, yeah. So, like, you're talking about, let's say, if I have drips, I have like a ketamine drip or something like that. Make sure to write the concentration on it so that you understand what's actually in the bag, not just, 12 hours ago I put 500 milligrams in a bag.
Yeah. Or God forbid that you started it and there's 11 minutes of it left, right, for our 90-minute transport time.
Right. I don't know that there'd be lots of time with it, but if we're actually doing a PFC, obviously I'd have sat on that patient for quite a while. I'd probably have customized whatever, if I'm doing pushes of analgesics or even drips, I guess. How would I convey that under a helicopter as far as, hey, don't bother with, 100 of fentanyl, give them, 35 is like the magic number for this guy. You know what I mean?
Yeah, that's a great question. And, I think, we want to talk about what the thought process is, when it comes to this handoff, or the thought process between, what we're going to do on the ground versus what we're going to do in the air. And, there's from the flight side, there's two things that we're concerned about. We're concerned about running out of gas, and we're concerned about collecting holes in the aircraft. And beyond that, medevac generally sort of, makes it up as we go along based on our skill in flight and our competence as aviators. And so, if we're not running low on gas and the LZ is secure, then we've got a little bit of time, and we can do a good, in big air quotes here, bedside handoff. And going back to what you said, that this is the most dangerous time, and this is it's not just dangerous in PFC. It's not just dangerous on the battlefield. This is a fundamental truth of all medicine. When we hand off care between providers, whether that's two nurses at shift change, or from one hospital to another during an interfacility transport, this is the most dangerous time, and this is where we see a lot of those medical errors occurring. And we're fortunate stateside and in civilian medicine to have these systems of managing risk and these controls that we've implemented, both in terms of robust documentation and systems of communication and accountability of care. And we don't really have the luxury of a lot of those things sort of natively in the military medical system. And so it requires a lot more teamwork. And you were talking about white knuckling, the last precious seconds of patient care before, they get loaded up and taken away. I think one of the resounding principles of prolonged field care or prolonged casualty care is that it is absolutely a team sport, 1,000% a team sport. No single, heroic 18 Delta, no 68 whiskey, no medical provider in existence is going to be able to manage this care for days on end without, the help of a well-trained team. And so, if you have people on your team that are able to fill out the TCCC card while you're performing your damage control resuscitation, that's baller. Even if they have terrible handwriting, at least there's something on the card. They can circle ketamine and write a number next to it, and that's a good start. And it only gets better from there. So, systems of care. Build your systems, train your team.
Yeah, outstanding. And you're absolutely right. Nobody's going to do this on their own. We have, stories of, fabled medics doing heroic things, but they always had help. They always had somebody that was, facilitating this thing to happen. You know what I mean? Whether it was running to get them supplies, whether it was moving somebody for them or holding pressure or just doing what they're told to do, you still have help, right?
Just so, your listeners know where we're kind of coming from, but we have a pretty good protocol book, the SMOG, Standard Medical Operating Guidelines. It gets a little wordy here and there, but there is a pre-transport checklist in the back there that is just that. It's a robust checklist for doing a pickup, usually from like a roll 2 or whatever, but covers a lot of these points. And I think, if you're interested in making sure that your teammates, make it through the night, kind of knowing our frame of reference and knowing what our front door looks like is valuable. And that's the pre-transport checklist in the back of our book. That, has things like confirming medications and double checking the airways, and then, just kind of other little administrative tasks about securing litters, etc. But it's out there. This is not something that medics are winging or making up as they go.
Yeah, no, absolutely. Especially if you're part of your plan, you're going to be, operating with, other agencies, other units. If they have an SOP, why would you not want to take a quick look at it?
Yeah, totally agree.
Absolutely.
Another question is, so say or how about you guys, you're going to go fly, you're going to pick somebody up. They've been seriously injured. What is your thought process on doing invasive procedures? Now, and what I'm trying to get at is, when do you decide I'm going to do this here and now on the ground, or maybe we take our chances and do it in the air, or maybe even we wait to get to the roll 2, roll 3, whatever. Kind of what is your thought process, your risk kind of stratification, if you will, on making that decision?
That's a great question.
Thank you.
So, Morgan, you want to field it first?
Yeah, I mean, I hate to say it. I hate to sound like a lawyer, but it depends.
Yeah.
I mean, it just depends on so many factors. And I think about, obviously, very, very obviously, the threat kind of governs, right?
Hmm.
That's the really easy umbrella answer. What's less obvious is let's take a relatively simple procedure like obtaining IV access.
Mm-hmm.
The pigment of the patient's skin matters. Is it going to be an easy stick? Is it the time of day matters? Is there plenty of ambient light? Like all these little subtleties, and it goes sort of to the clinical judgment of the receiving flight paramedic in this regard. But of course, everything is going to be easier on the ground, unless the threat it makes it impossible. But of course, things will be easier in a relatively stable, relatively quieter environment. But it's so hard to answer that definitively. It's so hard to put a bright line around a certain procedure. Best case for us, right, is that like everything works, everything's flowing, and we just kind of kick back and keep looking at the monitor, keep looking at the patient, look at the monitor, look at the patient. But I wish I had a better answer for you, because it's so very complex. I picked a patient up the other day from a search and rescue here stateside, and I could have done plenty of stuff, and it was actually a pretty nice day. But the patient had been on the side of a mountain for better part of 12 and a half, 13 hours, was very cold. And it was obviously more important that they get to the hospital and that they get warmed up and get to a hospital than it was that they get a little bit of pain relief, or that they get, a little bit of Versed to make the hoist emotionally easier for them.
Mm-hmm.
Long answer that's not really an answer at all.
Right.
It just really depends.
Oh yeah. And I absolutely agree. But now let's take security out. Okay. That's an easy one. If you got RPGs and hot steel screaming over your head, right, you need to move, right? So let's take that out of the equation. What about the patient's condition is going to tell you, I'm going to do it now, versus doing it in the aircraft, versus we're not going to do it at all. We're going to wait until he gets to hospital.
Yeah, I would say the things that would make me stay on scene are the urgency of the procedure, mm-hmm. and the complexity of the patient. So if this patient has no airway, is turning blue, and oxygen saturation's dropping precipitously, then I would need to obviously balance the risk, but do my best to secure that airway immediately as a life threat. And so the urgency of the procedure matters. And then I would say the complexity of the patient. So even simple procedures on a complex patient, I would want to do that in an environment that wasn't noisy, that wasn't vibrating, that wasn't dark. So if the stability of the environment is greater outside the helicopter, then that's going to be more conducive to a complex, invasive procedure. Mm-hmm. And then the either stay or go. So if in an undifferentiated situation where it's 50-50, my decision to stay or go is going to be based on the available help. So, unlike Air Force CASEVAC, right? So, if you call for PJs, you're going to get one helicopter, and the PJs are just going to pile out of that thing like clowns. It's amazing how many paramedics they fit in a single HH-60 platform. So, in addition to not having any guns, we also generally, doctrinally, only fly with one paramedic inside of a helicopter. Now, we were very fortunate. My last tour in Afghanistan, we made the decision, the command team made the decision to put 2 medics on every helicopter, both lead and chase. And so we had 3 sets of hands, including, a well-trained crew chief, 3 sets of hands to manage these patients. But if I don't have that, if all I have is a helicopter mechanic to help me manage a potentially difficult, rapid sequence induction or something like that, then I'm going to rely on the well-trained medic that I'm receiving this patient from, who knows this patient very well. And so if security is not a factor, if environment is not a factor, then I may elect to do a more invasive, more complex procedure on the ground before getting into the helicopter.
Mm-hmm. Because I've definitely, in training, I've watched a lot of guys, you can tell they're thinking about it, like, oh, he needs a chest tube, or his airway's starting to swell up, and you can just start seeing their head spin, and they know that it needs to happen, and they know that that it needs to happen, but like for the moment, like, he's okay. You know what I mean? They can tell, like, 20 minutes, 30 minutes, an hour, like, things are going to get real bad real quick, So,
I think this goes exactly to Max's point about predicting or having an understanding of the clinical course. If you're treating a patient and you begin to understand 20, 30, 60 minutes in advance of the patient handoff that a procedure needs to be done, understand that although that helicopter looks really large, and I'm sure it's a tremendous relief for the folks that get to load their casualties into it, it is probably, again, if we're taking security out of this, a worse environment for your patient to be receiving care in than the one that he just left. Mm-hmm. It's probably better for your patient to have these procedures, especially something like a chest tube, done where you are than done while they're moving in 3 dimensions, and to have the procedure done by a person who is, quite possibly operating alone. And I mean, like, alone, with nobody to turn to.
Right.
So that's definitely something to consider. Is that aircraft with the big red cross is not the hospital; it's the way to the hospital. The Army is really is considering some different crew configurations, like Max described, but ultimately, it's a pretty resource poor environment. And I'm talking about resources as simple as like just light or the ability to speak.
Mm-hmm.
Mm-hmm.
I hope that
or
makes
the
sense.
ability to move around your patient.
Yeah.
Yeah.
You know, it's an interesting picture you paint, and when I reflect on it, I think I've been in that situation. You know, you have two medics sort of looking at each other over the top of this patient, and we both know what needs to be done, and it's not getting done, and both medics have different reasons for not doing it. And it comes to mind that, you know, operational medicine, the source of expeditionary medicine that we're taking out of the hospital and bringing into the field, and that we are then taking out of a civilian environment and, you know, translating it over to the battlefield. Operational medicine is an order of magnitude more difficult than anything that we will do inside of a hospital. And if we are the people, you know, if we are the people who have elected to go this route, and in some cases been selected as the best to you know, be entrusted with this sort of operational medicine, then we need to be competent, independent of environment. And, you know, I've seen a lot of my colleagues practice things like performing an emergency crike, where they will have their kit prepared and ready, and they will, you know, come to the decision to cut this person's throat open, and they will very purposefully sort of time themselves and measure themselves against their previous performance, and always try to improve their performance regardless of the environment or the scenario that they find themselves in. And so, to me, in my mind, that demonstrates competence independent of environment. And, you know, I think if you find yourself in that situation where you're staring over the patient, you're thinking, well, I know exactly where all of my equipment is inside the helicopter, and, you know, I'm comfortable working inside the helicopter despite all of the, you know, the lack of communication and the lack of being able to hear and auscultate, being able, the lack of fine touch because everything is vibrating. You know, I'm familiar because I've spent, you know, X number of hundreds of hours sitting in that seat staring out the window, versus I'm here in a stable environment with another highly competent medical provider who can assist me in this procedure that needs to be done. And I'm just not comfortable doing it because I'm outside my normal environment. Well, that needs to be purposefully trained away, because that's an inherent part of operational medicine, in my opinion.
Yeah, absolutely. Another thing I try to get guys to think about is kind of like, I don't know if you want to call it wargaming or whatever, but have like predetermined endpoints. Like if, you know, like an example for an airway, you know, I'll ask them, okay, well, what SpO2 are you willing to accept before you do a crike, right? Or what amount of, you know, diminished chest movement are you willing to take before you do a needle D or a finger thoracotomy or whatever? And if relatively quick at giving you an answer, then you say, great, that's where your line in the sand is. If the patient moves beyond that, you've already made your decision. Now it's time to act. And I don't think, at least I'm not seeing it anyway, as people actually planning that stuff out. And I think the more frequently you plan it out in training, the faster you're going to plan it out in practice.
Yeah, I totally agree with that.
Absolutely.
And I think I frame it in my head as an if-then calculus. If-then.
Yeah.
If the patient's sats go this low, then I'm going to do this. In a way, you know, that gets to the cognitive offloading that we're all really looking for.
Oh, yeah.
You know, the problem is that you're essentially using the guidance that you operate under to formulate an ad hoc checklist. But once you've done that, once you have set up that matrix in your head, sticking to it kind of makes things easier.
Yeah.
You know, if you make a promise to yourself, fill it, and don't look for opportunities to modify it. Making the choice to modify those if-then matrices, making the choice to say, oh, I'm going to go ahead with the chest tube, and then not because, oh, you know, I can hear the helicopter, or they just called in on the radio, so they'll be here really soon. It is not going to make the patient care better. Mm-hmm. It may make you the person, you may not have to sign for this procedure going haywire, but it's not going to be the best thing for the patient to again, see that helicopter door close, wipe your hands of it, and then just come to find out that, you know, 90 seconds into forward flight, some crazy thing had to happen that ought to have happened 30 minutes prior.
Mm-hmm.
I'm thinking of this this video that came out years ago, and it showed I believe it was a ANA guy stepped on a landmine, and the video is shot from the GoPro of the treating medic. And at one point, the medic understands that this gasping patient needs a surgical airway, and a few minutes later, the medic pulls out the equipment to do it. Right. And then a few minutes later, he arranges the equipment. And then like maybe 7 or 8 minutes later, he finally starts with the procedure. And you saw like multiple times he looked back at the Crike setup. He played around with the equipment, and then he went back and did something else. Right. And the whole time this patient is gasping. And so in my mind, you know, that shows that he understood cognitively what came next, but there was a barrier there, whether it's a training barrier or something else that prevented him from actually physically executing that skill. And you can almost hear the gears grinding in his head when you're watching that video.
Oh yeah, I mean, taking a scalpel to somebody's neck is not a benign thing. You know what I mean? You know, I mean, we all know it looks an awful lot like something else, right? But, you know, I think just by pre-planning it and saying, okay, I'm going to accept this. If it anything less than that, I'm going to do this procedure, kind of just like offloads all the blame and responsibility to something else. So you've already done your, you know, if-then statement, if you want to use coding terms, right? But kind of offloaded all that responsibility for the situation on the patient or whomever. But you've already made the decision. Now it's just the decision to act. You know what I mean? And I think that's what people have to do. You know, that same medic, because what happens is, you know, he saw the guy was gasping for air, right? He got his Crike out. He's like, yep, this is going to happen. And for whatever reason, he convinced himself, it doesn't really need to happen right now. And he watched his SpO2 probably go down. And then he got to another, like, I really think this needs to happen. You know, maybe he took like an extra gasp and his SpO2 went up like, you know, 1 or 2%. And he's like, oh, maybe I think he's coming back, you know? And once he realized that wasn't going to happen, you know, then he finally did it. Versus just setting you know, your line in the sand and saying, okay, if it goes below this, this is what's going to happen. You know, I'm going to drop 300 milligrams of ketamine and I'm going to cut this guy's neck open.
Yeah, I think the Crike is the sort of best example of this. Everybody always says this about Crikes. The hardest part about doing it is deciding to do it. Right? I mean, everybody's heard that.
Oh yeah.
You know, but really the same could be said about any advanced procedure. And if that's the hardest part, if the hardest part of any advanced procedure is the decision to do it, then we ought to train that that training is really going to come from within. Mm-hmm. That's really going to be up to the individual treating medic to war game, like you described, these things out in their head, or say them out loud, right? You could say them to your colleagues, like, hey, you know, if the patient begins to present this way, I'm going to do this. You sort of speak your goals, right? Make those promises to yourself. And then it's easier to follow through on them. But the more that we sort of visualize these things, discuss them with colleagues, formulate these plans, and then stick to them, the better off will be, well, the better off the patient will be.
Yeah, absolutely. On to my last question. So what considerations, okay, so the patient's physiology, do you take into consideration before flight? And what I mean is, you know, what do I need to talk to the pilot about? Okay, say either I'm the flight medic, or I'm going to have to jump on the aircraft with the patient because there is no flight medic. What do I need to take into consideration and talk to the pilot about, whether it be altitude or speed or kind of that transition from vertical to horizontal in a rotary wing? You know, what do I need to convey to that pilot?
Yeah, a lot of great aeromedical physiology there. So let's talk about altitude first. So the rotor wing platforms that we tend to use in the military, they have a relatively low service ceiling. So if you strip out a Black Hawk, like absolutely strip it down to just what is essential to fly, that thing isn't going to get much above maybe 16,000 feet. I think the max altitude for a Black Hawk in the manual is like 18,000 feet. And that's pushing it. Realistically, when this helicopter is loaded up with medical gear and people and patients and whatnot, you're not going to see this helicopter fly any higher than it needs to. And so that's based on the intel assessment. So we're given a set of threats, and we're given a set of guidelines as to how we should counter those threats. And so if we have a lot of people with, anti-aircraft weapons, we're going to tend to fly low. If we have a lot of people with, small arms, we're going to tend to fly high. So basically fly where the threat isn't. How that translates to patient care. There's not a huge pressure difference between flying at 10 feet above the ground and flying at 4,000 feet above the ground. Now, there's definitely going to be people who are going to come back and say, well, the largest pressure change in the atmosphere of Earth is between 0 and 4,000 feet. That would be correct. However, is it a clinically significant pressure change? And the answer in most cases is no. Now, I'm sure there is some physiology that would be affected by that pressure change. But again, we have to go back to, what are we capable of detecting in this role of care, and what are we capable of managing? And so generally speaking, the helicopter isn't going to fly, high enough where we get into pressure and altitude concerns. I know in Afghanistan, when I was in Helmand province, I think our base altitude was 3,000 feet above sea level. And then we'd add another, anywhere from, a couple hundred feet to a couple thousand feet above that. And we had patients that required oxygen, and we monitored that, and we gave them supplemental oxygen where they needed it. But you don't really get into big concerns like that until you get up over, 10,000 feet above sea level. And then sort of in line with that, the practice of inserting or the practice of filling up cuffs with saline to counteract pressure changes it's that was, you know, it is absolutely true that the volume of a closed container is going to expand, or I'm sorry, a fixed volume of gas is going to expand as you go up in altitude or go down in pressure. That's Boyle's law. But, you know, it just doesn't bear out in practice. Like, we're not seeing these huge, you know, increases in cuff pressure as we go up and down a couple thousand feet in altitude. So I think in large part, altitude isn't going to play a big role when you're talking about rotor wing aircraft. If you're talking about fixed wing aircraft, well, that's a different ball of wax, and they generally pressurize their cockpits to about 8,000 feet. And if that's going to be a problem, then you can discuss that with the flight crew. And, you know, I'm sure if you got a chance to pin down someone on a CCAT team, they could talk your ears off about that. But for us rotor wing guys, you know, we don't pressurize our cabins, and so we don't fly that high. Yeah.
G-forces
in terms
are real.
Of takeoff.
You know,
yeah, G-force.
Yeah.
So in terms of like the takeoff, right? I remember Doc Rush had a PJ who they extracted, I believe it was a bear mauling from Alaska. It seems to be a large percentage of their emissions. So they got this guy on a fixed wing, and during takeoff, the G-forces or the forces involved caused a transient physiological change in their patient. And so it raised the question, you know, is this guy hypotensive? Is this guy tanking? Do we need to give him blood? And they ran a second set of vitals once they were in, you know, stable flight, and it was just a transient change in blood pressure. I don't expect you'll see those sorts of forces in a rotor wing aircraft. We do have some G-forces that we run into in all three dimensions, so X, Y, and Z, and especially if we are if we're taking fire as we're coming out of an LZ. So one of the missions that we ran in Afghanistan, we responded to an IED blast. We picked up a bunch of patients. This MRAP was just absolutely demolished, and so we split the patients, critical and non-critical, between the two aircraft. And as Chalk 2 is taking off, we received fire from an elevated position, and apparently they were just camping out waiting for us to fly by so that they could shoot us down. And the minute the pilots and the crew chief identified that we were taking fire, they dropped it right back down to the ground, you know, yanking and banking, doing their evasive maneuvers, whatever their pilots are trained to do in that circumstance. And you know, here I am in the back of this aircraft, not secured in a seat, you know, only secured to the aircraft by a tether, and I'm just getting tossed around. And, you know, that definitely makes patient care a little bit challenging. But fortunately, that period of flight only lasts a little while, and then we can sort of regroup and determine what needs to happen to the patient. So I think the biggest threats to the patient's physiology is me falling on them, or unsecured equipment, you know, hitting them, or, you know, when I'm being flung around in the back of the aircraft, you know, inadvertently pulling out interventions, you know, yanking out the IVs and yanking out the airway, which, you know, goes right back to what did we do to prepare this patient in the first place?
Yep.
Yeah, I agree with all that. And I think it's kind of, you know, it's unfortunate reality of our particular job in the military, like medics. You know, they love to listen to something and maybe like internalize it, maybe to a little bit, to some extent, but really then think like, oh, I wouldn't do that, you know, or I wouldn't fall on my patient, you know, or I wouldn't pull out the IV catheter as I was trying to set up a saline lock. And like, it's real back there. And if you've ever, like, you know, ridden backwards when you were a kid, ridden backwards in a station wagon or something like that, You get airsick, you get disoriented, you can't reach that thing that just flew forward. I mean, all this stuff happens. And so I'm with Max. I'm maybe not concerned necessarily about the physiological effects on the patient, as we transition speeds or, horizontal, vertical, altitude stuff. But I am really concerned about myself, just sort of being unable to reach that Coban anymore. That is very real, and it's not easy to train yourself out of it. You can't get in 100 car accidents to sort of train your body to respond to a car accident.
Yeah.
I mean, you could certainly try, but
yeah,
you try.
I think actually out of everyone in the back of that helicopter, the two people who are going to have the easiest time with the takeoff are probably the crew chief who's secured in his seat with a seatbelt and the patient who's secured to the floor on a litter. Everyone else is going to have a rough time, especially if we start taking evasive action. There's this condition that there's a condition that happens to people in aircraft that are maneuvering called the Coriolis effect. And what this, I mean, there's lots of Coriolis effects, but what this specifically refers to is your inner ear, the fluid and the loops in your inner ear that give you sort of your sense of balance. If the aircraft is sort of moving in one direction and you're looking down at the patient and you move your head and turn laterally and look out the window, then you induce a condition where the fluid in in your inner ear is all flowing in different directions, and it basically just hits the off switch for your brain for a second, and you just turn into a sandbag on the floor. I've seen people puke from this. I have definitely suffered this myself, and it is incredibly disorienting. And if you are the patient strapped to the floor facing the ceiling, you are pretty much impervious to this effect. So really these sorts of G-forces that we're talking about are more deleterious to the flight medic than they are to the patient in a lot of cases. And then what was the other thing? Yep. Yeah. Lost it.
No,
it's gone now.
That was it. But yeah, no, I've been in the back of the helicopter treating somebody when the pilot starts, juking left and right. And I think you're right. Probably my biggest concern was I'm going to fall out. So,
just think if you delayed putting a chest tube in your patient because you thought that we were going to do it, and then all we did was barf on your buddy.
Right.
That's suboptimal.
Yeah, emesis therapy is not indicated.
No.
Yeah, and it it's interesting. The one of the flight medics that I served with referred to me as the fun sponge, because I would find a way to suck the fun out of any situation by pointing out things like, hey, if you fly without the pilot's doors on, it induces a convective current in the back and makes all of our patients hypothermic, which then kills them down the line. Or, if you fly with the windows open or you fly with the doors open, yeah, you look like a badass, but what are you doing to the inside of the cabin? What are you doing to all these, pieces of medical equipment that are now covered in dust,
Right.
And so really, like, the right answer tends not to be the cool answer in a lot of cases, which is unfortunate.
Yeah. Yeah. As a medic, we are definitely everybody's mother, and tell people to put that down and wash your hands and do all those things. But do you guys have anything else you'd like to add?
I have a few more things written down here. So you were talking about talking with the pilot and what do they need to know? And I think knowing your resources within a geographical area is important, especially if we're in a developed theater. So is the local FST the most appropriate destination, or does this guy need to go straight to the roll 3? And if so, what are the constraints there? Do we have enough gas to make it? You talked about speed of flight, and I can tell you that the helicopters pretty much fly at one speed, which is as fast as we can reasonably go, without sucking the guts out of the engine and causing mechanical failure, or without burning so much gas that we just don't get to our location. And so, these air speeds are fast. We're talking 120 miles an hour, around there somewhere. So we're going pretty fast. So I don't think in a lot of cases, the pilot's pulling an armpit full of collective is going to really significantly reduce your flight time and create a clinically significant outcome for your patient. So speed isn't necessarily the biggest factor, but communicating effectively that they need to change course and go to a different facility, that's going to be based on your understanding of the patient's condition and what's available within the theater.
Okay. So, I mean, that conversation, is that just as simple as, hey, we need to change course. I need you to go to wherever.
Right. And then that becomes a discussion between the crew. So if you say, okay, we need to go to this roll 3 because this guy has a neurological injury, I think most medevac pilots are going to, say, okay, we'll do what we can to make it happen. Mm-hmm. But the limiting factor there, again, is the capabilities of the aircraft. Like if we're going to burn out and crater into the desert, 2 miles away from the landing pad, that's a no-go. And we're going to be landing at the FST, and we're going to refuel, and we're going to transfer this patient.
Right.
This is really analogous to. I'm sorry, Max.
Go ahead.
Go ahead and start over.
This is totally analogous to civilian paramedicine. You can't take a stroke patient to any hospital. You have to go to a stroke center. You can't take somebody who's having a confirmed heart attack to just any hospital. You have to take them to some place with a cath lab. And, if we make that decision on our team, the 4 of us, 2 pilots, crew chief, and medic, the pilots they'll again, all things being equal, listen to us. They should.
Mm-hmm. They'll crunch the numbers, certainly.
Crunch the numbers, right. Hopefully they don't get into a medical argument with us. But it'd be really cool. It's just like Max says, if a treating medic on the ground, conventional force, or special operations guy on the ground can shortcut that for our minds. If that guy can say over the radio or at the time of handoff that there's some sort of indication for a specific facility, great. Then we don't have to sort of rediscover it again in the back of the aircraft. So I feel like it's a little bit unfair because all I've been saying is just like, that the initial treating medic needs to sort of like do all the interventions and, kind of have the long-term plan, but I guess that I really am advocating for as much of that either mental work or actual physical work be done before transport, because it does not get easier.
Right. Well, I mean, most of that information comes from pre-planning, which, everybody at least in the soft community, if not everybody in the DOD, are used to planning, right? And then Hopefully. It's a matter of, missed report. Okay. I have a head injured patient. If I'm done my planning right, I automatically know, hey, he needs to go, here, right? What I don't know is if you guys know that. So, if you, hearing that missed report or the first, few lines of a 9-line are, aware that he's got a neurologic injury, are you going to put enough fuel? Like, are you going to be able to do the calcs to put enough fuel to go from my location to X, you know?
Yeah, and in a lot of cases, we're sitting on the pad with a full bag of gas, and we only ever start flying at 100%. So, generally speaking, we're not going to stop and get gas before we head out. We pride ourselves on being able to launch within a very short window, and so I think our average time on my last tour in Afghanistan, we were off the ground in about 7 minutes after receiving launch authority. And I know that, depending on the environment, the unit that I was with just completed a tour over in the Middle East, and they were flying with external tanks, and they were expecting, 2-3 hour transports. And so it just depends on, like you said, that pre-mission analysis of what is our coverage ring and how far would we need to have to fly in most cases.
Yeah.
The last thing, that I have for you is sort of an open invitation on behalf of the entire, Army aviation, medical aviation community. Just an open invitation for any unit, any ground unit, special, conventional, to come on over, knock on the door, and introduce yourselves. Every medevac unit is going to have a slightly different set of TTPs. And every environment is going to demand that the medevac unit sort of adapt their TACSOP to the demands of the mission. And so the best way to figure out how to hand your patient off to these flight medics is to talk to them and just set up training, set up your hot load training, check out how they configure their aircraft. Because, there's a difference between a slick UH-60 and a fully configured HH-60. There's going to be a difference between a brand new HH-60 off the assembly line and one that's been stripped down for use in a combat environment. There's a lot that you can remove from those aircraft to make them more light and maneuverable. And so the only way you're going to know what the capabilities are is if you come on over, knock on the door, and have us give you a tour. And along with that, set up the training. Set up any speed balls that you need. So if you want a resupply along with your patient, you don't want to just get a bag of normal saline with a couple 18 gauge catheters taped to it, thrown at you as we leave. Set that stuff up beforehand, and we will absolutely grab that as we head out to your location so that you can get extra medical supplies.
Yeah, very good. One last thing, you talk about open invitations. Max and Morgan here also running their own podcast, which I really like listening to, Dust Off Medic. If you guys don't mind plugging yourselves, why don't you tell us about it?
Silence. Yeah, thanks for saying that. Max and I are 2 of 6 co-hosts for the Dust Off Medic podcast. For Army folks, Wayne is a Navy SAR med tech, and John, we just brought on board, is a Coast Guard rescue swimmer. And the normal format of our show is to go through our standard medical operating guidelines and kind of do a deep dive of each guideline per episode. We break it up a little bit here and there. We try to we've taken a lot of cues from you, Dennis, and the awesome work that you've done, and we've even poached some of the guests that you've had on. But we try to do a deep dive into into a single guideline per episode, really focusing on our role in the back of a rotary wing platform, and it's nice to have perspectives from different services. Everybody's got their own kind of way of doing things. And we're trying to be a place where helicopter flight medics can go to hear some of these issues discussed with an expert usually from within the DoD somewhere, and it's been a steeper learning curve for me to figure out how to operate some of this podcast software than it was for me to become a paramedic. But
yeah, so
it's
we
fun.
publish an episode every other week. You can find us on Instagram and Facebook, and we have a website, dustoffmedicpodcast.com, where we post our show notes, links to articles, and you can find the episode pretty much anywhere that aggregates podcasts. So Apple Podcasts, Google, Spotify, and a lot of the other apps that you can download on your phone. And yeah, like Morgan said, we try to take a walk around the DoD and see what other people are doing in terms of their protocols. And we try to apply some critical thought, pros and cons of every protocol that we look at, picking it to pieces and seeing what applies and what can potentially be done better.
Yeah, I mean, I really like it. I'm being relatively lazy in that I'm letting you do my research for me, and then I just lean over the podcast and see if I can pick anything out when it comes to ARIVAC and considerations for it. So I definitely appreciate that. All right. Well, I really appreciate it.
Thanks
Guys.
so much for.
Gosh, I'm so excited to be on your show. I mean, it's just like, we made the big time. We did it. I've been listening to this guy for years. So,
Yeah, definitely. Thanks for having us on, and really appreciate the conversation.
Podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.